Okay, good morning, Mr. Mohamud.
Good morning, everybody. Good morning.
Okay, you can hear.
Thank, thank, thank you. Yes, I can hear you, and I'm logged on. And thank you, everyone, for joining in. Welcome to what I hope will be an informative, interactive, happy session as we look at different areas, piece by piece, segment by segment, into ethical issues, ethical forms and our responsibilities within the hospital medical setup. Uh, I'm now sharing my screen. There we are, and I'm quite happy to be here. I see quite a few people have already logged on. I just want to confirm that you can hear me. Some Dr. Veru, can you hear me?
Yes, you
Awesome.
can.
Thank you. So, hi all. Like I said, I'm Mahmoud, and part of the ethics committee under the leadership of Dr. Veru at AKU Nairobi. We are very happy to share what we know, our experiences, and what we can all do together as we go forward into this new era where so much is changing, especially in terms of AI, use of AI. Ethics is becoming more and more significant, important, and very critical aspect of healthcare, especially. For today, we are not looking at research ethics. That's a different ball game, but we are looking at aspects of ethics, and I'm going to touch on what informed consent is all about. So I hope you had a great session yesterday, which was also an introductory into different aspects of ethics, and we are now narrowing it down into segments because there's a whole lot of segments that make ethics what it is. And we are now going to look at what informed consent is all about. Generally, we all have a very overview idea of what informed consent means, and our normal common sense just tells us that informed consent is all about letting the patient or the opposite person uh, understand what they are giving consent for. But as we are looking at it, we'll realize that there's so many different aspects attached to informed consent that it can become quite complex on its own and very sensitive, very touchy, and in today's era, very legally important. So I'm hoping that by the end, we'll all understand more and more principles about informed consent, the aspects attached to it, so that we can put it as a whole. So today, the world of medicine is monitored and regulated so that patients are treated in a certain standard, a certain format. And one of these formats is ethics. And we generally have an overall concept, an overall idea of what moral principles apply to ethics. But as we look at it, we'll realize that it's much more complex, it's much more complicated, and it has so many different angles to it that if we were to say that we just use good common sense, it's not going to be enough anymore. That could work in the past, where we were led by values, by principles, by our own judgments of what we thought was right and wrong. And today, those very judgments are in question. That when we think what is right and wrong for the patient, is that then ethically correct? And so the idea then is, and this is a past, that if one is practicing good clinical medicine, then ideally, logically, that would have meant that they're practicing ethical medicine. That's not true anymore because the law comes in, moral judgment comes in, values, principles, and guidelines that have been formulated over the years comes in very strongly to help us to understand and to be guided by what good ethical medicine is. So the law tends to complicate it even more because it brings in so many different dilemmas that when we look at trying to make a judgment in terms of ethical principles and taking informed consent, then just going by the law is not enough. Because if we take simple examples about the law, to terminate a pregnancy, for example, or not to terminate a pregnancy, then, and we go by law, then law alone can contribute to making that decision. But when it comes to an ethical dilemma about whether to terminate or not, whether that pregnancy is in fact a human being or not, whether it is religiously ethical or not, then the law alone is not enough. And a lot of times we are guided by intuition. Intuition is our gut. Our gut tells us that this is the right thing to do. And the idea then is to marry and combine and find a balance between law, intuition, good clinical medicine, etc., plus all the morals and values that are attached to informed consent as a way, as a guiding force to see whether we are making the right decision. And sometimes there isn't a straightforward answer. So, informed consent is defined as the study of morality. It's a careful and systematic reflection on analysis of moral decisions and behaviors, whether it's past, present, or in the future. And past would be an event that has occurred, present would be how you're dealing with it now and the decisions that are being made, and future is what are the implications to the future, and are they all ethically, morally, principally, and medically and legally binding? Are they safe? Are they the right way to do? And by trying to combine all of these, we then understand and examine different aspects of moral life. So, in a nutshell, then informed consent is an attempt to arrive at an understanding of the nature of human values and applying that and how we ought to live. And that this is where dilemmas come in, because when we think of how we ought to live, then is that right or wrong? Because how do we judge for others? And what then constitutes right conduct? All those together form aspects related to morality. So when we look at today, in today's era, the idea of getting informed consent is being as holistic as possible. And of course, it's very, very almost impossible to take every aspect of holisticness, which is a biopsychosocial model, apply that, and then think that we have got informed consent. But as we look at it, we'll see there's a lot of subjectivity surrounding it. What we think is right, what we feel is the right way to do things, what we feel is the moral way to do things based on our own understanding, our own background, etc., can be very, very subjective. Is good, good? Is bad, bad? Kind of thing. And the idea then is to take into account the person concept, taking the human being into account, taking them into decision making, taking them into making sure that understanding is absolute, so that there is no ambiguity, there is no future hit back in terms of saying that one did not understand, or we may have thought they understood, but they didn't because we did not use right understanding methods. So taking things into context, that helps into decision making. The context of not only our side in terms of a hospital, but very much taking the context of the person, taking their background, their values, their principles, their culture and tradition. And this is the biggest difference between informed consent today in the West and informed consent. What we are now using, quite friendly in a good way, is the Ubuntu style, whereby we are taking our own context of African culture, African traditions, human concepts, values, principles, myths into account to make sure that that is all completely contextual when we are helping someone to make an informed consent or an informed decision. And the idea then is taking personal responsibility, not only from the medical point of view, but also from the patient point of view, that the patient is also taking personal responsibility into the pros and cons, the consequences of their decision, such that when they are giving consent or not, then they are taking responsibility based on what the understanding is. And this is the tricky part, that they have to really, really understand pros and cons and then make their decision. We may not like the decision. The decision may not be what we want to hear, but the decision at the end of the day, and I'm sure Dr. Vero has touched on autonomy, whereby they make the decision based on their understanding of the entire context. And that's personal responsibility. But from the healthcare point of view, personal responsibility comes back to the person trying to get informed consent. Have they done everything needed to help the other person understand fully the pros and cons and consequences and implications before they give consent or deny consent? So this then takes into account the need to focus on that particular issue rather than what universal laws are or universal understanding is or universal norms. It focuses very much on the person, but it also focuses very much on the importance of taking that consent and the understanding of taking that consent and the issue related to what consent is being taken. So it's concerned very much with the reality of things. It's not concerned with research. It's not concerned with global understanding. It's very, very focused, very contextual, and very personalized. In that way, when you try to obtain informed consent, the idea is that the authority is being shared by the person trying to give the information in a context, but it's also shared with the person who informed consent is being taken from. And that way it brings in the law into place, it brings in the safety netting into place, that God forbid, if there are consequences, then the consequences have been understood, they have been acknowledged, they have been documented. Remember, documentation is key. And then we'll come to the consent form, and we realize that just taking consent on a form does not imply informed consent. That is the modus operandi. That is the what makes the consent legal. But the understanding can be very, very different, and it can vary from what consent is being taken about. And that's the touchy, sensitive part. Of course, autonomy. I'm sure you've all touched on that. Autonomy is them taking responsibility for it. That's the patient in this case in a hospital setup, and having the ability to decide what they want. We may not like that decision, but we'll walk with them knowing that they have made a decision based in their best interest and in their full understanding of the pros and cons. And then this ties in with universal theories, universal rules, which are now what we call modern ethics. But remembering that the context is very important, the biopsychosocial model that is applied is very important. We are guided by universal theories and rules, but we are also guided by our own inner instinct and judgment and concepts that we have come back with, and some can be biased. A very simple example is whether to transfuse blood or not, whether to treat or not, whether somebody wants to take chemo or not. And of course, we will all definitely have our own personal take on this, our own personal biases of this. And that's okay. We are not saying that you have to put your bias on hold. Your bias can come in the context of giving them informed information. But the autonomy rests and lies with the, in this case, the patient. And so when we are looking at giving informed consent, then there are personal moral qualities and values and principles that guide us. And very often, this takes into then account our own biases, our own upbringing, our own experiences. If we've had a family member or a parent who went through cancer and they had a horrible time going through cancer, taking chemotherapy, then we come forward, even consciously or unconsciously, we come forward with our own biases. Our own bias would guide us in how we portray and how we try to get informed consent. And it can be very subtle. Bias can be very subtle. It doesn't have to be verbal. It can be non-verbal. It can be very, very subtle coercion aspects that can come into it. And so the idea then is to look at these values that I've put on the screen. And we are not saying that we have to be holy, holy. We are not saying we have to be holier than thou kind of situation. You have to be yourselves. But if you want to take informed consent and you want to walk with a person, you want to walk with a patient, then these are values that are going to guide you, guide your approach, guide your own integrity, but also guide your conscience. Because remember, you want to go home and sleep knowing that you have done your best. And even if the decision that is being made is not what you would have liked to hear, you are okay with it because you will walk with them in terms of helping them to understand the consequences of their decision. A very, very simple non-medical example is this. If a couple came and said we wanted to get divorced, then our own personal biases can come in. If we've had a bad background or a bad relationship, we might say, yeah, why would you tolerate all of this? I mean, just go part and go your ways. But when you reflect on it, there are consequences to that. Of course, there are. But if you ask them to stay, then there are also consequences. So the idea then is to help any patient make a decision knowing pros and cons and consequences, whether they make a decision in one direction or the other, and that they are going to understand it. And it doesn't mean they are okay with it. It means they have made their decision in the best way they know, based on their context, based on their circumstances, based on their principles and values. And then they are going to be okay with it. And the consequences that come of it, they know beforehand that these are the consequences. It doesn't mean those consequences are okay. It doesn't mean that they're happy with those consequences. It can be very painful. But they understand why they have made that decision. And when they've made that decision, when those consequences come, they know that those consequences have come based on a decision that they have made where you have walked with them to understand full implications of the decision and the consequences that are coming, and what the decision could have been otherwise, and what those consequences could have been. And so we are not saying that you need to be priestly about it. We are not saying you need to be holier than thou about it. But you have to be in the shoes of that patient to be able to walk with them, understand fully their context, and help them to make a decision regardless of what you feel is right. So in the past, this is what we used to see. Culture used to come in, and this culture relativism that warns us about the danger of assuming that our preferences are based on rationality. And supposing somebody needed to have, let me use the same example, a termination of a pregnancy, and in a teenager, then our biases, our cultural relativism is a theory that tells us what are the dangers of assuming that our own preferences are rational enough and they are correct and right and they should be followed. And therefore, when we are using the cultural relativism theory, this requires that we keep an open mind and practice tolerance and practice unconditional, non-judgmental approach. That's the only way that you can make sure that your conscience is going to be clean and clear and free when they make a decision that you may or may not agree to. So many of our practices are appropriate only for one particular community. But if we take different communities and we take the 40 odd communities and races and tribes that we have in Kenya, then almost if we look at all those 40 plus, there are overlaps, yes, of practices and values and principles, but they are also individualistic in their own way. And the idea to be is to be as open about that individualism so that you don't make it a bias. And these are tricky ones, difficult, because naturally we are all always guided and we always have a background of our own bias. The idea is, like I said, not to forget your own bias and to say I can be, but to accept what the bias is and to acknowledge the other person's context. Then there is sensitivity. And they're being sensitive to culture and religious differences. And I'll give you a very simple example. If and this is not necessarily medical, but if somebody had to make a decision about having a termination of a pregnancy because it was a health risk, then we automatically come in with our health biases. We automatically come in with our sensitivities based on our values, principles, religious upbringing, etc. And the idea then is to be able to take their context, their cultural and religious differences, so that we are in line and congruent and balanced with the values of the patient and the ethics of the profession. Because to terminate or not to terminate seems pretty clear. It's black and white. But it isn't when you bring in culture. It isn't when you bring in religion. It is very black and white when you bring in health risks and say if we don't have a termination of that pregnancy, there's a health risk or a life risk. But when you look at it from a religious and cultural difference, then this becomes very touchy, very sensitive, and very difficult to negotiate, and sometimes also very difficult to accept. And that's the idea here, to find these balances, to be as sensitive as possible to other people, in this case patients, cultural and religious differences, so that they can make an informed decision on the kind of consent they are giving. Because we say, if they give consent by signing, yes, I'll go ahead with treatment, that's consent. But if they don't give a signature, then it doesn't mean they've not given consent. They've given consent not to give consent. That's the whole idea here. And we then have to be congruent and quite balanced and okay with it, to walk with that patient, accepting what they want. And a lot of our communication generally may not necessarily be verbal. We'll go into non-verbal and modes of communication as we look at means of getting informed consent. So when we look at ethics of care, then we are looking at relationship based, and the idea is to form some kind of a relationship with your patient so that they can make a decision knowing that you have understood and you have some kind of a shared relationship based on the accounts that they're bringing, based on the ideas that they're bringing, based on their values, based on their concerns. It also means interpersonal relationship, having care, compassion. They are emphasized so much because if you do not practice the interpersonal relationship, if you do not practice the care and compassion as nurses, as medical professionals, then there's a very subtle non-verbal bias that comes in that makes that patient automatically feel that they've not been understood, or that they have made a decision, but you're not happy with it. And you don't have to be happy, but you can acknowledge that I don't like that decision. I think it's very risky, but I walk with you. And I'm okay because it is your decision and you have understood pros, cons, impacts, consequences, and then you are making your decision. So it may not be what we want to hear, but it's what they are okay with. And okay doesn't mean they're happy with dying, for example. It means that they understand the implications of it and they have acknowledged it and they have chosen that as the best way forward. So the ethics of care then focuses on the relationship involving care, responsibility. They are trusting you as you are trusting them. You are trusting them to make the best decision, but they are also trusting you to give them the right information. They're also trusting you that you have their best interest at heart and that you are sensitive enough to their situation. So those are the basic ethics of care. Then characteristics, the characteristics of ethics. These are based on virtues, and virtues are our own guiding internal principles, our own values, our own conscience, if you want to call it. And virtues are also based on your biases, your own background. And culture comes in very, very strongly when we talk about virtue based. And the focus then is on the type of person you are in terms of your own character and personality rather than the actions. And the type of person you are, we're not saying you have to change who you are, but you have to keep these ones in mind, that this is what determines at the end of the day who you are. And we are not saying you have to be all empathic or you have to be all sincere. That's not true. You have to be yourself. And being genuine is very, very straightforward here. Being genuine is what guides you in how you will communicate the need for that person to be able to make a decision. And healthcare workers must display compassion and trustworthiness and their own integrity rather than trying to guide the patient into making a certain decision which they may not be happy about, but it's what the physician or the healthcare worker wants. And remember, the patient will always be able to tell, because when they go back and reflect on what you have told them, that's when the biases start coming up. That's when conflict starts coming up. That's when they start seeing he or she said this, and this is what it meant. And did they try to make me make a decision? Or did they push me into making or into giving consent, for example? And now when I reflect back, I would not have made the same decision I made if it was someone else. And we hear this a lot when we come to ethical conflicts. We hear this a lot that the physician did not tell them about certain aspects of what was needed to make a decision. Very subtle, small points, but put together, they are very, very life implicating and decision implicating. And therefore, that becomes a very tricky place then to be, because the last thing you ever want in your life is a patient coming to tell you that you did not tell me about this point, or you did not explain this, or you did not see that I understood, or you used language that just went over my head. I know sometimes language can be an issue. And even though we generally think that a lot of patients speak English, there are a lot of patients who don't understand fully English and would rather go into vernacular or would rather go into our second language, which is Kiswahili. And if the doctors are not understanding that this patient is not getting what I'm saying and they're using jargon, then that physician is going to go back and reflect and feel a little guilty. The problem comes when the patient starts feeling that. The physician or the healthcare worker will live with it, and that's their conscience. But don't forget that patient, when they come back or they go back and reflect, and they start thinking that this doctor or this healthcare worker didn't tell me something that I understood, they use this word that I didn't understand, then that's not a healthy place to be. That's where conflict starts coming in. And the next time you go to see that patient, you can see a change in their attitude. You can see a change in their demeanor of how they are interacting with you. So we are also guided by medical ethics, which is the respect for all of these. And I'm sure a lot of you have a basic concept of what this means. I'm sure a lot of you have touched on this. And these ones, they keep coming up. Every time you'll learn about ethics, every time you learn about informed consent, then these are your medical ethics guiding principles. The one that I usually bring in and add over here is something called altruism. Altruism is knowing that they have made a decision from the heart, and very difficult to understand. But if we are following these principles, then altruism comes in very automatically, because if you are true, they will make true decisions based on what their heart is telling them. Yes, we know about beneficence, doing good and benefit to our patients, but needing very focused on being clear about the risks and harms and benefits. And I'm sure you've touched on these, so I won't beat about these ones too much. But the reason I bring it, because this will lead us to our next few slides, which is then all about informed consent, and doing no harm. And then this one usually brings into mind what we call the Hippocratic Oath. That and I use that a lot when I'm talking about kidney transplant. When we are taking kidney from a donor, then the question comes in: is that infringing on the Hippocratic Oath, which is first of all, do no harm? Are we doing harm to a kidney donor? And then we weigh the benefits and say, yes, there is harm, but there is also benefit, and the benefit outweighs the harm. So going forward, justice is treating people not only equally, but fairness of treatment. And a lot of this came up during the COVID time, where decisions had to be made on the fair distribution of the resources that were available, using a ventilator or not, taking somebody to ICU or not. And criteria was set which guided us on as to whether somebody would go to ICU or not, or use a ventilator or not, based on their age, based on how sick they were, based on probability of survival, etc. Very painful decisions, sometimes in making sure that justice is given, but it forms a very essential part of decision making, taking consent, and going forward. And you see, when we are talking about justice, and let's say we use an example of somebody who says, I want chemotherapy, I want to leave. I know the doctor says prognosis is 50-50, but I can't afford it. And then, so the resources then is not about the hospital resources. It's not about what is available. It's about what they have that they can put in. Is that going to have huge consequences for them and their families, and going multi-generational? And do they make a decision based on that, knowing what the consequences are if they make a decision to go for chemotherapy, or they make a decision not to go for chemotherapy? Confidentiality, and I know we will have this as a topic in the next day or so. And generally, this means, one, privacy. The person and their interest control the access of others to themselves and to information. And this is a lot about information, not only you giving them, but what you do with it, how you manage it, and how they are going to be able to manage it, taking autonomy into mind. People may decide that I don't want to tell my family, for example, and they push you to say, do not tell my children that I'm dying. Do not tell my children that I have a life-threatening disease, or a disease that has social stigma, mental health, HIV, etc. This is where it means it's the concept of safeguarding the information, not only about the person, that of what information they reveal to the doctor, but also the information that the physician or the healthcare worker is giving to the patient. And what do you do with that information? How do you safeguard it? How do you make sure that confidentiality is maintained within the ambit of the law as well? That's the tricky part. And I know this will come up in our next day, so I'll move on from there. And so when we look for respect for autonomy, it's meaning self-rule, meaning the patient makes the decision, and it's the right of every individual to make their own decision, like we said, based on the pros, the cons, the consequences, the implications, and then us being okay, even if we're not happy, being okay with that decision, knowing that they are making the decision in the best way of what they understand. And our responsibility then is to make sure that they have understood it fully. And that is what we are calling informed consent. Do they have enough information given to them in the right way, with the right understanding, with the right knowledge of the implications and pros and cons, without manipulation, without our own bias coming into it? And have they made a decision that is against their will or within their will? So some difficult ethical dilemmas, and autonomy always brings this in, where we have challenges, where people may have learning difficulties or language challenges, or even if they have other mental health issues or developmental challenges. And we look at how informed consent affects this very specific cohort of people, such that decision sometimes is made by others in their best interest. But then, is that right or wrong is always a dilemma, always a room for discussion, and always sometimes leaves a gray area in terms of when that decision is being made. Was it what the patient would have wanted? And sometimes very, very difficult to negotiate, but also very difficult to sometimes take home. When we looked at autonomy, and we are now coming to informed consent in its entirety, yes, there's, like we said, confidentiality, which will be covered up in the next day, truth telling, and how much of the truth is the truth, and how much do you tell in the truth, and how do you communicate that truth, and how courteous and respectful are you of the dignity of that patient? Do you tell them bluntly, like some physicians and some healthcare workers can be very blunt and say, get on with it. If you don't do it, you will die. Nobody really wants to die. But then sometimes it's put very bluntly. I know this comes up a lot when we do obs-gynae. Sensitivity can be an issue because it does not mean that the doctor is not trying to be sensitive, but sometimes the patient is more sensitive or needs more understanding or compassion or values or empathy than the doctor has given or is able to give. And then that infringes on their dignity and their respect for that patient. So autonomy is a touchy one, and I'm sure we've gone about it. A lot of people know what autonomy means in its general sense, and almost every lecture you will come across autonomy and justice and beneficence and non-maleficence, etc. Generally, we all understand it, but let's now go to informed consent. So this is the process by which a patient learns about and understands the purpose and benefit and potential risks of an intervention. And this includes, say, clinical trials that are being done, or whether they are receiving treatment that has so much of a downside that should they agree or not agree to participate in, say, a medical trial or a particular treatment. And this has ethical, legal, and practical implications. Ethical, is it ethical to give somebody a trial where we know at the end of it, it might prolong life, but it may increase suffering? It might prolong life, but it doesn't ensure life, and they might die from the side effects, etc. And then is that ethical or not? And decision making is very, very tricky over here, especially when it comes to because everybody clings to hope. Everybody wants to cling to life. And then it has legal implications that if they die before and you told them, I think you'll be okay. I think you will live another couple of years. And then supposing they die in 3 months. And then that comes to bite back and said, I remember you saying this person would have lived 2 years. We thought we would do ABCD in 2 years. You didn't say that the last 1 year they would be completely bedridden. And that's how informed consent gets very tricky. Were they told that you will live 2 years, but your last 1 year you will be a complete vegetable, and therefore you'll not be able to do anything. And when you tell somebody they'll live 2 years, they think, oh, 2 years is good. I can tie up my loose ends. I can make a will. I can sell my property. They don't realize that it's not all hunky-dory. It's going to be what we call chalk and cheese or chicken and feathers, whereby they'll have good days and they'll have very, very down days. And in down days, those are wasted days, so to say. They can't do much. They can't achieve anything. And so the practical implications come in then. And so when we look at informed consent, it has a process. So the initial first one is the patient understanding fully with all the knowledge that is being given to them of pros and cons, and then being helped to make a decision completely voluntarily. They are accepting the decision and they are accepting the consequences of the decision. And eventually they are giving you permission by providing informed by consent. And then that consent means ongoing, means going back to say, you made this decision, are you okay with it? You made this decision. You remember we talked about you having downtime. And yes, decisions can change. People can have a second thought and say, I thought this would be okay. It's not okay. I want to make another decision. And then they weigh the pros and cons and implications of that decision and the availability of that changing the course of, say, treatment. And that's called ongoing consent then. So consent is not just a one-off. It's not taking a signature and saying, this is what we agreed on, this is what we are going with. There is the aspect of continuous ongoing consent that is very important in healthcare. So the idea then in a nutshell is giving them information. And remember, information comes from very many different ways. Dr. Google is heads-on. Anybody who is sick will most likely, today we say it's about 90% of the people will have gone and got information from social media, from media itself, from Google, etc. And then this has to marry and tally with the information that the healthcare provider is giving so that you take away the myths, the misinformation of what they've got, and then trying to understand, have they understood it fully? And that's why you can see this is a complete cycle. It's an ongoing, you remember we said ongoing consent. So there's information, there's understanding, there's the voluntariness and being ready to accept that understanding and all that information before they make consent. And then there is the ongoing consent of the decision and thinking, do they want to make a change? Do they want to rethink? And are there options for it? That kind of thing. And when you're giving informed information, the idea is to help them to understand what part can they change? What part will they reach whereby there is no return? And say, it's too late to now think of chemo. It's too late to now think of radiotherapy. ABCD has happened. And we are past that point, but this is what can be done. And would you like to make a decision again? So this is a constant cycle. And therefore, informed decision is not a one-off. Like I said, it's not a signature that you take and say, they given consent, we are good to go. We are never good to go in its totality. We are good to go for now. And the now is what is important. But going forward, tomorrow is a new now. Day after tomorrow is a new now. And therefore, there is that constant need to help them to understand and to be okay with decisions that are being made and the processes with which that are being followed and the consequences with which they are enduring. So when we are giving informed consent, the idea is, have they understood in normal lingo, understandable dialect, basic, simple English, Kiswahili, or vernacular? Because terminology changes. And when you use from English to Kiswahili, the meaning changes. And therefore, when people interchange, then the meaning can change and said, yes, but you said sawa sawa, meaning okay. But you may have meant it as sawa, we are okay. And you can see how it can change thinking, especially in tricky times. And so then them understanding, of course, the benefits, the pros and cons, the complications and consequences of their decision, and what is prognosis. What is going to be the outcome? Prognosis does not mean are they going to recover or not? Prognosis means what are they going to go through? What is going to be the next stage of, say, their illness? What is going to be the next stage of their treatment? That's the prognosis. And the idea is to keep revisiting this to help them to understand. Because remember, patients, if you tell them you will be okay, they can stick to that and they stop hearing anything else. And the idea then is to have the right setting for them to be able to understand lack of interruptions, communication skills, etc., to be able to, for them to really take on fully what you are trying to tell them. Because remember, if you tell them you will die, then information stops there. And if you then continue talking, they probably are not hearing anything. And when you come back to, they'll say, yeah, I heard you telling me I'll die, but I didn't hear you telling me there is hope. Or I didn't hear you telling me there was a treatment. So the idea then is to walk. And that's why helping them to constantly confirm what they understand is very, very critical. Because we can say one thing, but it relates to something else, or it creates more conflict for them. And so when they are giving consent, then how voluntary is that consent? How informed is it? And the idea then is to help them to confirm that they are happy with whatever decision they are making, happy in quotes, that it is fully informed. It doesn't mean they're happy with dying, but they understand the implications of it, and they've said, in the best way forward, I'm making this decision knowing it is in the best interest. It doesn't mean they're happy about it. Consent is the legal document signed by 18 years and above in Kenya. But remember, when we take consent, it's very important also to take assent. And assent allows minors under 18 to convey their opinion. Yes, the decision is going to be made by a parent or a guardian. In other cases, next of kin. But assent in minors is very important, because the last thing you want is taking a child for chemotherapy or an amputation or a surgical intervention, and they didn't know about it because the parent has made a decision, or not taking because their parent has made a decision. And we have this especially in adolescence. This is very, very common. It's a bit tricky when it comes to small minors, like small children, because generally the parents are making the decision and the child is the one suffering the pain and the discomfort. But when it comes to teenagers, they are very able to make their decision, and then it becomes a family conference or it becomes a family decision as to taking that the minor, the below 18 age group, taking their ideas, their voices into account before informed consent is taken. And this is where coercion comes in, where very subtly or very overtly, very openly, families can actually come out and say, I want you to do this. You are going to do this. You're going to have this surgery. You're going to have an amputation. And that 17-year-old is saying, if I don't have a hand or a leg, I'd rather die. I will not be able to live. And this, we've come across this a lot in osteosarcomas in the teenagers, whereby they say, we don't want an amputation. We'd rather not live. And the parent are saying, oh, there will be life. I mean, you can use a prosthesis. So the idea then is to have that joint conversation so that the coercion is minimized and the decision making is by everyone, even though the consent form is being signed by the legal guardian. And that's why we said, when they sign consent, does that mean consent? It's a yes and no. There's legal implications to signing, but consent does not mean the legal document in itself. So when we come to the other aspects of informed consent, they are the threshold elements, where we are looking at the patient and trying to make sure that they have understood and there is voluntariness and lack of coercion They can be understanding, they can be suggestions, but if coercion comes in, then you can be sure that that's a patient that is making a decision which is not totally informed. It is often then coerced informed consent, which comes back to bite later on, especially if things don't go as planned or they are not happy with the outcomes. And so threshold elements are elements that you must ensure that there's understanding, they are voluntarily making their decision, that there was sufficient disclosure of the information, the recommendation of the plan is understood by them, accepted by them, acknowledged by them, and that the decision for or against what the decision is being made, and that is all about informed consent to do or not to do, and that they have authorized it with the full understanding. Like we said, full understanding does not mean happy about it, but full understanding means understanding fully the pros, the cons, the consequences, implications, etc. So the principles are competence for them to understand, but also for the giver to give that information. It's informed that they have fully understood and taken all the information that they need to make that decision, that decision and the consent they are giving or otherwise is voluntary, that the timing of it is right, is not too premature or it's not too late, and it's very specific to their situation. It's not based on, say, guiding principles that are out there in terms of generalization. It is very specific to their context, to them, themselves, and them. So why are we taking it? Informed consent is important because it guides the way forward in terms of the condition or disease. It helps you to plan the purpose and nature of the intervention that they are going for. It allows them to understand the consequences of it and also to understand what are the alternatives. And in today's day, people are very quickly looking at alternatives. Do we go for Ayurveda? Do we go for herbals? Do we go for holistic care? Do we go for prayers? And these alternatives can be taken into account, the risks and implications understood, and the consequences of it. And sometimes, in many cases, you can marry the two. Sometimes you can't. Sometimes you can take herbal with modern medicine. You can take prayers with modern medicine. You can take goodwill with modern medicine. You can take some Ayurvedic medicines, but not everything. So as long as they understand the alternatives, Chinese medicine has come in a lot. Acupuncture, aculaser, these are alternatives. But do they have pros and cons? As long as we understand that, we understand the risks, and we understand the benefits, and we understand what the prognosis is going to be in case they decide to take one route or the other. And patient understanding means we take special attention to children, like we said, getting assent from them. But remember that when we are talking with people who are, we are taking consent from people who are mentally challenged or people who have left a will saying, in case I die, this is what I want. Then do we take, and kidney donation comes in here. Today in Kenya, we are not using cadaver kidneys, but we are coming to it. Eye transplants, ocular, etc. These are coming in. Liver transplants are going to come in the future. Do we take it from somebody who's dying, who is incapable of giving consent and making a decision? And how do we go along that? And in emergencies, if somebody is brought in brain dead, but they had already said that they wanted to give a kidney, for example, and the family is now, then how do you get that consent, that last minute consent? Is it then going by their written instructions? And lack of written instructions, then is the surrogate allowed to make a decision and give that consent? Would that have been in the best interest of the patient? These are touchy, sensitive ones, needs a half a day to discuss. But the idea is to give you an understanding that informed consent is not only with patients who are able, it is also informed consent with patients who are not able. And usually guardians, parents, etc., will make these decisions as long as they have been given all the information and the pros and cons, and that has they been understood. Because sometimes you can't relate to somebody who's mentally challenged or autistic or etc. or brought in brain dead. Then the decision is made by significant others or next of kin in this case. And some barriers then, like I said, are the people who are incapacitated. It means that they themselves can't make the decision, but it doesn't mean that informed consent cannot be taken. It can be taken from significant others, from family, from friends, from a next of kin, etc. But the idea is to involve the number of people that you need to involve to make sure that there is no conflict and that you don't have bigger conflicts coming up. In the interest of time, your setting, the timing of the conversation is very important. The privacy, the timing that you make sure that other interruptions are not there, the phone is not ringing, the room is not being used, etc., so that you can have a one-on-one, non-disturbed conversation. Exploring patients' fears, concerns, the nature and what it involves. We've talked about this in general context as we've gone along. Potential implications so that they can make a decision also taking into account their concerns if they do not take treatment. So communication in informed consent is the ability to convey as much information and ideas effectively. And we know it means speaking, listening, observing, and empathizing with the patient so that they understand it fully. So that there's no ambiguity, there is no later on that they did not hear or did not see. These are all how body language is, and we say very often informed consent involves all of this. It's a whole mumbo jumbo of how body language and non-verbal communication is all about. So there is verbal, there is written, and there is what you do not say. But you are saying it not by words, but by implications, not by words, but by your non-verbals. And if you take all of these into account, we are all in a good place to get informed consent. And just going on, as we want to close, these are all just summary of everything that we have talked about and reinforcing. And remember we said informed consent is ongoing. It is not a one-off, and it is not about the signing. We have a couple of minutes, and I'm happy to take any comments, questions as we go forward. Of course, we've got tomorrow, and we'll be looking at the topic for tomorrow then, which as far as I know, I think at the moment, unless it changes, is talking about confidentiality. Anyone wants to add here their experiences, sharing? I know I've not given much time for that because informed consent is very broad, very wide. The floor is open to all of you.
Thank you, Dr. Merali, for
Thank you,
such
Felix.
an informative talk. My name is Dr. Mzibi. I chair the Ethics Committee of Aga Khan Kisumu, and I have a couple of questions.
Sure.
The first set of questions is how to format the informed consent form.
Yes.
I was listening to your talk and I was just imagining an informed consent form. Should it have a place for consenting and a place for declining? Is it a must that it have a place for declining? Because I'm looking at it in terms of possibility of later litigation, that if there's no evidence that the patient declined whatever procedures presented to them, then they might as well decide that if things go wrong in the future, they are suing Dr. Musibi because there's no evidence that they actually declined that procedure and you didn't do it.
Yes. And you're raising a really, really significantly important thing that's coming up even more now and now. And it's about declining, and it's also about refusing treatment. It's about saying declining means refusing to some extent. Doesn't mean we are not going to treat at all. But the idea is documentation and a record of your conversation as far as possible needs to get included in your informed consent form of what has been discussed, the pros and cons, and what the patient's final decision is. So when it comes to the signing, it's informed consent to say, I have understood, I have been informed fully, and I'm giving consent to that understanding. And therefore, I'm not giving consent for the treatment. And yes, it's a good idea to have it as a separate thing, saying that I'm declining chemo, but I'm happy. And when we come to goals of care, there's a form for goals of care. That one is very specific to that, and it does cover that aspect.
Sure.
But it does no harm to modify the form and format it to capture areas that are touchy and sensitive.
Can I comment?
Sure. Yes, Dr. Veer.
Yeah. So currently we are updating our generic informed consent form. And because of the Data Protection Act and the fact that all information belongs to the patient, one of the additions that we have had is a part of refusal of treatment, that the patient can say, I've been explained everything, I know my diagnosis,